To discuss multiple myeloma from diagnosis to treatments and beyond. And my name is Fiona Evans. I am the Director of Patient Relations here at Massive Bio, and I'm joined today by Dr. Claudio Cerchione. Welcome.
Thank you, Fiona. Great pleasure to be here. I am an Italian hematologist, currently based in Meldola, Istituto Romagnolo per lo studio e la cura dei tumori di Amadori, which is not far from Bologna, located in the northern part of Italy, and I'm leading the research and clinical activities in multiple myeloma, from the diagnosis of the patients to the treatment, and many preclinical projects about all what is changing in multiple myeloma, which is a revolutioning disease in last year. And I'm particularly glad today to share with you my ideas and my thoughts about what is changing in multiple myeloma. So thank you for this opportunity.
Thank you. And thank you for everything that you're doing for your patients. It's truly appreciated. So we'll jump right in with what are the common symptoms and signs that lead to a multiple myeloma diagnosis?
At first, we have to consider that a patient with the suspicion of multiple myeloma could start with a suspicion de novo, or starting from a pre-existing condition, a pre-myeloma condition, which could be a monocular gammopathy of unknown significance or a smoldering myeloma. So the first thing is to consider the differential diagnosis between the plasma cell dyscrasias. Then a multiple myeloma, symptomatic multiple myeloma, could start with the CRAB criteria, CRAB, which is an acronym in which C is calcium, R is renal failure, A is anemia, and B is bone disease. These are the criteria, the classical criteria of multiple myeloma. Together with this, we have to consider the biochemical parameters, starting from the M spike, the monocular component, which is something that we quantify to understand the size of disease. Together with that, we have to consider the proteins in the urines, and particularly evaluate them in 24 hours, and also balancing them with the free light chain, and particularly free light chain ratio is another very important exam. It's really important to conjugate these biochemical parameters with a radiological assay, and particularly PET-CT is the standard of care for this patient, and we can combine that with new generation imaging techniques, such as, for example, whole body MRI. In my institutions, we perform in all the patients newly diagnosed in the relapsed refractory setting, or also the smoldering myeloma, we perform the combination between the PET-CT and whole body MRI, so that we can evaluate in the best way the bone disease, but also the extramedullary disease. And I think that the next future will be to increase the diagnostic tools for our patient, in order to perform as best as possible the characteristic of the myeloma in the moment in which it presents, and in the moment in which the disease relapses. I think that this is the next future, to improve the diagnostic tool.
Excellent. Yeah, it sounds like there's lots of testing currently, and hopefully, improved in the future. So, can you explain the stages and risk stratification used in multiple myeloma diagnoses?
Usually, we consider multiple myeloma according to previous scoring system. We have ISS and ISS. They are mostly based on the cytogenetic risk, particularly on fish, for instance, in situ hybridization, which characterize some genetic lesions historically known as a good or bad prognostic parameters. However, I think that considering the immunotherapy and the potential target therapy that we have commonly available today in our daily practice, I think that the next future will be a molecular characterization. I think that as we have done in other hematological malignancies, we have to switch to a molecular-based prediction. And I think that the idea to conjugate the cytogenetic risk together with the molecular parameters, particularly in my institution, we are studying a gene expression profiling project in which we demonstrate that the molecular stratification improves not only the diagnostic tools for our patient, but also the stratification and also the prognostication. I think that this will be something that will permit to develop, I hope, as soon as possible, a target therapy, because I think that we need a molecular-based approach. Today we call all the myelomas multiple myeloma, but I think that we have different presentations, and in the molecular basis, there is the key point. I think that as soon as we study the molecular basis of multiple myeloma and we develop projects in which we develop biomarkers in our daily practice, we could improve and we could optimize the drugs and combination that we have currently available, finally optimizing the outcome of our patient. I think this is the next future.
Yeah, very, very important. Absolutely. So, can you tell us more about what exactly multiple myeloma is and how it differs from other cancers?
Multiple myeloma, first we have to consider that is a blood tumor, blood and bone tumors. And as all hematological malignancies, it is a systemic disorder. So we have to consider that multiple, because as a multiple localization, which could be several, it differs from the plasmacytoma, the bone plasmacytoma, which is one localization of myeloma, and it is treatable in a different way. In myeloma, we have several localizations and we have to use systemic drugs. It starts from a hyperproliferation of disease plasma cells which are changed in their form and in their characteristic, which proliferate in the bone marrow. These plasma cells stop the bone marrow activity, perform an invasion of the bone marrow, and could go also in some organs, and took to the symptoms that I have explained before, so to the developing of a Crab criteria, so a potential renal failure, a bone disease, going into the different organs. And that's why the patient could understand the idea that could have a so serious disease starting from the signs and symptoms. However, the pathogenesis is becoming more and more clear in last year, because we know that there is an alterated bone metabolism, and we know many things also about the idea of bone lytic lesions. So I think that we are going to understand the different steps of pathogenesis, and thanks to that, we are also going to study better the plasma cells, which are the key point of multiple myeloma. And we are going to select some biomarkers expressed by the malignant plasma cells. We have developed, thanks to that, in last year, some targeted therapy, for example, monoclonal antibodies, anti-CD38, which revolutionized before the relapsed refractory setting, and now have been integrated in frontline treatment of multiple myeloma. We know BCMA, which is another targeted treatment that we can develop today. We know CD3, we know other targets that we are going to better understand, that today have given to us the possibility to develop biomarkers-driven approach. And I think that the next future will be to understand more targets, which could mean also to have more potential immunotherapies. I think that this is today the state of the art in the idea of the pathogenesis of multiple myeloma. But I think that considering the change of outcomes, we are going to understand more and more the idea of starting to define the pre-myeloma status, and particularly to go to diagnose and treat the high-risk smoldering myeloma, is a new idea that is starting to develop in our minds, in order to treat the patient before that they get ill, before that they develop symptoms. The idea to treat the patient before that they are sick. And I think this is the key point. Today, understanding the pathogenesis, understanding what's happening, what's changing, I think we can prevent the idea of developing multiple myeloma. That's why everything is being revolutionized, starting from the diagnostic tools that we have available.
Excellent. Yeah, that would be fantastic if we could, find it before, causes any symptoms. That would be amazing. Can you give us an overview of the biology of multiple myeloma and how it affects the body?
Yeah, this plasma cell, malignant plasma cell, hyperproliferate in bone marrow, and then they could go, as I've said before, in different organs. So I think this is the key point, starting to understand what happens, how myeloma becomes a systemic disease. And I think that today we have to perform a correct diagnosis in order to understand where myeloma is going to diffuse. I think that for our patient, we have at the first to explain that hematological malignancies are never localized, are never in only one organ. Right. These are diseases related to the blood. Blood is everywhere. Blood is systemic. That's why I think this is the first thing. In hematology, we don't have metastasis. We don't have the concept of invasion. From diagnosis, everything is systemic, and that's why we have to use a systemic approach to treat our patient and to eradicate the disease.
Yep, that's right. Great. Okay, so regarding treatments, what are the primary treatments for multiple myeloma and how do they work?
The treatment of multiple myeloma, as I was saying before, has been revolutionary in the last 3 years, and particularly starting from frontline setting, we have a new backbone, daratumumab anti-CD38 monoclonal antibody, which has been integrated in our daily clinical practice in transplant-ineligible patient and transplant-eligible patient. We define the eligibility to transplant according to several factors: the age, the comorbidities, the concomitant medications, the characteristic that define the patient in his totality. Transplant-eligible patients are treated today with daratumumab added to VTD, so bortezomib, thalidomide, and dexamethasone, with the following conditioning regimen: autologous stem cell transplantation, consolidation treatment, and the following maintenance, which is currently in our daily practice lenalidomide, but many new agents, many monoclonal and bispecific antibodies are arriving also in our maintenance for our patient. Moreover, we have to consider that in transplant-ineligible patient, we had the same an immunotherapy-based approach with daratumumab, which has became the backbone also in this patient, together with lenalidomide. DARA-RD is the most used approach, but also DARA-BMP, bortezomib methylprednisone, is another opportunity, the only fixed duration, which we can use in frontline setting. In relapsed refractory disease, we have many new agents. We have a new generation monoclonal antibodies such as isatuximab in several combinations, together with the carfilzomib and second generation proteasome inhibitor, together with the pomalidomide, which is a new generation immunomodulating agents. We have several monoclonal antibodies such as elotuzumab, which is being combined with the pomalidomide and dexamethasone. We have new target therapies such as belantamab mafodotin, active on BCMA, selinexor, which is becoming maybe the new standard of care in lenalidomide in a refractory patient, together with bortezomib dexamethasone. Selinexor VD is being approved in Europe as soon as possible, also in our country, because in some countries can use that. Moreover, we are going in the era of ultra-novel immune therapies, starting from bispecific antibodies, teclistamab, elranatamab, alnuctamab, and many others are arriving, and also with new target-based bispecific antibodies such as talquetamab. Moreover, the CAR-T are not anymore a dream. They are arriving in our clinical practice, and I think it will be really important in the next future to define which is the right patient for every drug. I think that we have to personalize as much as possible the treatment, the combination, according to what we have available. We have to select in a personalized way which drug and which combination to use according to disease characteristics and many other factors.
Yeah, absolutely. I know you did touch on different factors that play a part in treatment options. So, everyone should keep that in mind. Are there any emerging or experimental treatments on the horizon that we should be aware of?
So at first, about the factors that we have to consider, as I was saying, is not only the age, is not only the comorbidities, but today we can understand which are the characteristics of disease in terms of bone disease, of renal failure, so to avoid nephrotoxic agents and something like that. We can also go to evaluate the previously used drugs and combination in order to select the best mechanism of action that could be the most useful option for that patient. But moreover, we go to consider also the quality of life, the capability of the patient to travel for infusion in hospital, the presence of a caregiver. And I think that we have to balance all these factors to select the treatment. And going into the experimental treatments, yes, we have many new opportunities today in our clinical practice. We know, as I have said, the biology of myeloma, and we are going to perfection what we can use today. I think today we have at first to consider that we have new immunomodulating agents, cell modes are arriving in our clinical practice. I have particularly great experience with mezigdomide, which is a particular synergism with the proteasome inhibitors, and I think is a drug that is particularly active also in patients who are refractory to classical immunotherapy, to monoclonal antibodies, and so on. Moreover, we are going to explore new opportunities of maintenance, and we have to consider that bispecific antibodies such as elranatamab have a potential role also in deepening the response after autologous stem cell transplantation. And I think that we have to consider, starting from this subset, that the new endpoint is going to become the MRD negativity, the minimal residual disease negative, is something that we should aim in order to prolong the life expectancy, but also in order to be more than dreaming when we speak about curing multiple myeloma. We are going also to explore the new potential combination of specific antibodies, the idea of combining drugs such as teclistamab or elranatamab with daratumumab, comparing to the regimens that we have today available in our clinical practice. So I'm thinking to Majestic 3 trial, Magnetism 5 trial, and something like that. We are going also to explore new bispecific antibodies. ABBV 383 is, I think, a perfect partner for many other agents. We are having an experience also with this drug, and I particularly appreciate between the specific antibodies, the new immune therapy salnutamab, which I think that as a single agent has shown incredible data in terms of efficacy, fast response, but also deep response. And I think that we have to consider that this is a subcutaneous drug which is potentially being combined with many other agents, and I think that this will be in the next future. But in a represented patients, I had excellent experience with this agent. We are going to explore the CAR-T and particularly where positioning them, if could have a role in alternative to autologous stem cell transplantation, if they could be only for relapsed refractory setting. And I think that as much as we discover them, we became able to maximize the result and to minimize the side effects. This is something that we have to consider, I think, for our patient. If we prolong, if we have switched from the idea of a fixed duration to a continuous treatment, today we have to balance all the side effects to permit to our patient to maintain an excellent quality of life. This should be our end point, together with maintaining the efficacy. We have to optimize the tolerability of the agents and combination that we have available. And this is something that we are going to improve year by year, day by day, I think, for our patients.
That's great. That's very important also. So are there advantages to combining different treatments such as chemotherapy, immunotherapy, stem cell transplant for these patients?
Absolutely. The idea of combinations is something that helps us to maximize the result, as we were saying. The idea of combining different mechanisms of actions, exploring potential synergism between the agents, could permit to fight the malignant plasma cell from different point of view, also attacking not only the cell but also the microenvironment, which makes the cell alive. And I think that we are also exploring not only the concept of immunotherapy, that was something of incredible in terms of efficacy and tolerability, but also the idea considering the concept of chemotherapy. Meflufen, for example, is a new concept of performing chemotherapy, and I think that some patients are showing a total refractoriness to immunotherapy approach, but a great chemosensitivity. I think that also in this sense, biomarkers could help us to understand which is the phase of that malignant plasma cell and which is the best approach. Maybe someone are particularly refractory to immunotherapies and should go in some other ways. And I think that the idea of having new generation chemotherapies could help us also to explore these fields.
That's great. Yeah, definitely. When you're treating your patients, how do you decide on the best combination of therapy for those patients?
I consider the first, which is the clinical history of that patient, where the myeloma started, which were the drug used, which was the tolerability and efficacy of different drugs, so to which mechanism of action the patient and the disease seems to be sensitive. And I decide, considering in the moment in which I select a new treatment, which are the characteristics of disease. So if there is a bone disease, if there is extramedullary disease, if there is a renal failure, if the patient has a previous hematological toxicity, if the patient has a neuropathies, the cardiac status, which could prevent the use of some drugs, the presence of caregivers, because some patients cannot travel alone anymore. Some patients are unfortunately alone, and I have to consider also this, because today we have also potential domestic approach. And I think that I select the best regimen according to all these characteristics. In some of them, I wanted to totally revolution the idea of selecting a new, totally new mechanism of action and new drugs, and these are the patients going to revolutionary agents and to totally new mechanism of action. I think that this is something that arises from the wonderful results that research reached in last year, because if we go with our mind behind, and we consider that in 2015, 2016, we had available only few drugs. We had bortezomib, lenalidomide, pomalidomide, and chemotherapy. In that case, we could not consider so many characteristics, because we could only use what we had available to combine the drugs, but not anything more. Today, thanks to the approvals, the many approvals of drugs and combination that we have available, we could balance all these factors in order to explore the best possibility for our patient. That's why we can consider all these characteristics. These are something that arises from the wonderful results of clinical trials. Clinical trials in myeloma last year have taken wonderful results and incredible approvals. We are improving the outcome of our patient year by year, and I think that quantity and quality is never a problem. We can position, and I think that today we should also improve our sequencing to understand which is the best moment for that drug or that combination. And this means to switch to a personalized approach. I have to understand which is that drug or that combination the best for every patient. And I think that we are going to personalize day by day the treatments for multiple myeloma patients.
Excellent. I know the treatments have come a long way in the past 10 years or less, so that's great news. And clinical trials are very important to us here at Massive Bio, and we want to ensure that all patients understand the benefits of clinical trials, how they help them individually and also help all the other patients to come. So that's something very near and dear in our hearts. When we talk about common treatments or treatments for multiple myeloma, are there common side effects that you see with certain drugs?
Every drugs have side effects. There is no drugs, also not
Right.
not the antineoplastic treatment. Every drug have a treatment. We have to understand which are the side effects to minimize, thanks also to the supportive care. For hematological side effects, we have the growth factors starting from GCSF, erythropoietin that helps our patient, the transfusion dependence, and something like that. But also in terms of extra hematological disorders, which could be potential side effects, we have to understand and to prophylax the patient. I think that prophylaxis is the key point. We have to understand also in terms of potential infectious side effects. We know that immunotherapy means to revolution the immune system, and that's why we need to protect our patient with antibiotics, antiviral agents, and I think that we are also going to improve the use of vaccinations that we have available in our medicine daily practice. I think that we have to understand which is the potential side effect of that drug, to teach the patient how to discover them, how to counteract them, but also how to monitor them. I think that today we know really in a very good way how to monitor the patient, also not only for the efficacy but also for the tolerability of the drugs. But I think that considering the achievements that we are reaching in multiple myeloma, the supportive care is something that we are going to care about. I think that another key point is to consider as important as a treatment also the supportive care that we manage for our patients.
Exactly. Yeah, it's very important for patients to, as you said, know ahead of time what are those common side effects and to share that with their physicians and support staff so that it can be taken care of right away. So, on to clinical trials. Can you discuss the importance of clinical trials in advancing multiple myeloma treatments?
At first, we have to consider that, as I was saying, we had brilliant results from clinical trials in last year. We have to teach our patient that being part of a clinical trials is being part of tomorrow treatment. I think that this is the first thing when we present the idea of clinical trials. I am particularly engaged and I love the idea of offering to our patient the best to improve. When I present to a patient a clinical trial, I explain that if we are investing together with the company in a potential new treatment, is because we are sure that this should be better than the standard of care. So they have to understand that they are not as mouses going in a clinical trial, because someone are particularly afraid of that. Yes. I explain that as worse as possible, they have the same treatment that they could have in everyday practice, so the standard of care. But if they are in the experimental arm, they could be part of the new revolution that is going to happen in that setting. And moreover, being part of a clinical trials means also to improve the monitoring of disease. There are some particularly important exams, tools that we are not able to perform in our everyday practice. I'm thinking, for example, to MRD monitoring, to new molecular assays that are considered inside the clinical trials. And I think that these are other advantages that the patient could obtain being part of a clinical trial. So I think that is really important to train the patient, but it's also really important to train our colleagues about the importance of clinical trials. I think that we are in a moment in which the network is particularly important. We have to collaborate with our colleagues, and we should know where clinical trials is available in order to offer to the patient both the opportunity. I think this is something that we have to consider when we decide the treatment with the patient, because I think that we have to decide together. When I speak with my patient, I consider my brainstorming, my think tank about what I'm considering in selecting the treatment, and I have particularly to explain to the patient the clinical trials opportunity in that setting. My idea, if I have selected the trial being part of my institution is that I strongly believe that trial is the perfect option. So the patient, if the patient has the eligibility criteria for that trial, this will be my choice, and I want to guide the patient to understand why I'm choosing that instead of the standard of care. And I think that it's particularly important also to explain to our colleagues that even if they have not available clinical trials, they could refer the patients. And we have many colleagues, friends that refer many patients, particularly in relapsed refractory setting, to obtain something of different for several reasons. They want to change mechanism of action. They want to optimize the drug offering to their patient with the new combinations in which that drug is the backbone and is not alone. I think that there are several causes for which we could refer a patient to clinical trials, but the idea of referral, I think, is something that we have to work about, because some patients want also to travel to obtain the best treatment. The dream is to have also the possibility of decentralized the trial, the idea of having a trial everywhere, and that the patient could have the best option along the street of their house. I think this is our dream. But in this moment, I think that if we refer the patient to a close institution, maybe we could change the outcome of our patient with small efforts. So I think that we have always to consider what is available in the background and not only in our own institutions.
Yes, absolutely. And I know, as a physician, you're working so hard and treating your patients that it's not always possible for you to know what's going on outside of your institution. So sharing that information, with other physicians is super important. And when you're talking to your patients, what do you think they should know about participating in a clinical trial? And how do they find those, if it's something that is not available at your institution?
I think that we should develop registries of clinical
Oh,
trials
yeah.
in which the patient could match their characteristic with the potential availability of trials. I think that we should consolidate the networks with our colleagues, and particularly also the awareness of the patient about the research opportunities. I think that we should make democratic the clinical trials, not only for patients who have the capability to go in a research institution, in academic institution, but we could train. And I think particularly in networking, I think that the scientific societies are something really important, because we can interact, we can exchange ideas and projects inside the boards that we perform in scientific society. But not only, I think that also the patient associations are really important. I think that in next future, offering services for our patients, we have also to train them about the opportunities that are available in general in our country. I think that it's really important to explain to the patient that something could be available not in their own institution, but not far from them. I think that networking is the best that we can do, because if a patient is followed by a colleague and the colleague strongly trusts that I'm giving a very good opportunity, they know my institution, they know what I have available, and they know that we could manage the patient together from the moment of starting a clinical trials. I think that this is really important. We have also to understand the importance not only of drug-based clinical trials, but also about the observational trials. I think that these are also something that is going to change the outcome of our patients, because they help us to understand which are the current unmet clinical need in our daily practice. So I strongly understand that also these research opportunities is something in which we have to work together and we have to perform networking. I would love to have a registry of the patient in which all the patients are inserted, and in which we could have a warning when a patient is potentially eligible for a clinical trial with the map where the trial is available. This is the next future. However, I think the key point should be also artificial intelligence. We are in the world in which we can do many things about thanks to artificial intelligence.
Yeah,
I think
definitely.
that this could make us to make aware us about the best opportunity for our patients. So I imagine one day in which all the characteristics of a patient are inserted in a system which matches their characteristic with the clinical trial availability, and they could conjugate in order to make us to understand which is the best option for that patient. This is the next future. However, we have many tools available, and if we optimize them, we can obtain this today.
Absolutely. And we're definitely working towards all of that. You know, we have our own artificial intelligence based technology that identifies clinical trials for patients in a specific location. So we're working hard on that.
And we
For
will work
patient,
hard with you, because I
yeah,
think
good.
that
That's great.
your
That's good.
efforts and what you are doing is something that we really needed in our daily practice. So I think that this is something that will help us to change the outcome of our patients. I'm sure about that.
Yes, yes, absolutely. How can patients actively participate in their treatment decision-making process, including clinical trials?
I think that the awareness of patients is something that we have to work on. I think that
Mhm.
educational activities for our patient should be something that we consider particularly important and particularly strategic, because the patients wants to know. The patient goes to find information on websites sometime without a guide. I think that we have to perform activities in which we train our patient from the diagnostic process, from the characteristic of disease, from the treatment opportunities, and also about what is a clinical trials and how they can particularly being part of them. I think that today the patient and the caregivers are particularly trained. So I think that if we perform educational activities, they can really be part of the decision-making process. When they are in front of me, I always explain what we have available and what we are thinking, and also about the idea of prognostic situations of their disease. I think that they have to be aware about that and about what we are thinking, and also about the idea of what is changing in last periods, because the patients want to know which are the novelties. I think that they have to be aware about the treatment, but also about the diagnostic tools, which are the best exams to monitor as best as possible their response. Because this is another important key point. When perform a diagnostic tool, when having imaging, when evaluate PET-CT, when to perform biochemical exams, when they have to do bone marrow and something like that. I think this is the next future. The patient should understand why we are doing that, why in that moment, and what we are thinking about their disease.
Yes, absolutely. Can you share how you think multiple myeloma diagnosis affects a patient's emotional well-being, and what support there's available for that?
When a patient receives a diagnosis of multiple myeloma, the life totally changes. Because at first we have to consider that we explain that this is a chronic disease. Chronic disease means something which they have to live together, something which is treatable but not curable, and this is something that we have to explain. Maybe in next future we will be able to definitively eradicate multiple myeloma, but today we are able to chronicize the disease. So I think that the psychological impact is something of really important, not only for the patient, but also for the entourage. So for the partner of patient, for sons and the potential close people. And I think that we have to explain to all the group that follows the patient what's happening, what is changing, and what we will do in next future and in a long-term future. I think that today we have to explain to the patient that the treatment have a different tolerability, and they can continue to live, continue to work, continue to dream, and continue to have an expectancy of the future. So I think that it's really important to interact with the psychological status of our patient, and I think is a particularly dramatic moment, more than the diagnosis, the moment of relapse. I think that in that moment, when you think that all what you have done has failed, is particularly frustrating. So we have to explain to the patient that what we have available in that moment is something in some way better of what we performed before. And year by year, we are changing our actions that we can do. I think that we have to try to discuss about the patient. I want to explore also the mind, what they are changing. I have a patient that ever started to do incredible activities, sport activities, going on the horse. I have a patient of mine that has become, he has, in the moment he's in maintenance, has no bone disease, has no particular risk, not running, but going in his life. I think this is the best proof of what is myeloma today. The treatments in some moment are hard, the side effect exists. We have not to say no, they are perfectly tolerable. No, they have a problem, but we can fight together with them and we can manage together. I think that is important to speak with the patient. I think that sometimes the patient wants to know more. So I think the empathy, the relation that the patient exchange with their doctor, I think is particularly important. The patient have to think that you are fighting together, and that's why I want to have a strong relation with my patients. I want to live what they are dreaming, also apart from the disease, what they are living. There are some patients. Recently, a patient of mine inside the phase 1 clinical trials, which had a terrible relapse of disease, had a stringent complete CR, and had married. He had the mind to plan the wedding. He had an incredible wedding, and he has started to think to a future, to sons, and so on. So I think that this is another important thing that we have always to express to our patient, is that myeloma is not hereditary, is something that we could not transmit to our sons, our daughters, and so on. Some patient thinks that this is an hereditary disease. This is absolutely not true. And this is another thing that we have to evaluate the comprehension of our patient about that. So I think we have to evaluate all what the patient is thinking about his disease and about the treatment that is performing. Some patient, when they go in relapse, they think that he's going in palliative care. Is absolutely not true. I say that if you are performing a drug, a combination, and we are monitoring you for the disease, is because we think that you can win your battle. We are continuing to fight, and I think that maybe we could definitely win the fight in next year. I'm sure that we will be able to cure and to eradicate multiple myeloma. The basis that we had in last 10 years make me to strongly think that. I'm sure about that.
We've come so far. It's amazing, really. So what are the long-term outlooks for multiple myeloma patients, and what follow-up care is necessary after treatment? I know you talked briefly about patients going on and living great lives, so that's fantastic.
I think that we are changing our objectives, because we want, before to obtain the result, our endpoint was progression-free survival, overall survival. We had to increase the survival. Now we want the deepness of the response. We want to reach MRD negativity. That means the deepest response as possible. So at first, a changing of our aims. Moreover, we have to understand which is the best monitoring, balancing the return to the life, but maintaining the idea of monitoring in the best way. So I think that we have to discuss with the patient when we have to perform biochemical exams, why the treatments are continuous and never stop, why we changed the idea from fixed duration, because we need the continuous control of the disease, and also when perform imaging, because some patients will love to monitor them every month every time because they are particularly afraid of the reawakening of disease. So we have to express when is the right moment. We should not be too much invasive in performing unuseful exams, but also never forgetting that the relapse could happen. So how to balance the exams that we have available together with the normal monitoring that we perform to our patient, the idea of defining when seeing the patient for a visit, when to give to the patient also the possibility to monitor in some moment some exams with their general physicians, with which we are also developing a strong relation. When is the moment to come to us? When is the moment also to perform a particularly important exam? I think that this is the idea to thinking in a long term, and the idea that in a long term, potentially a patient who has achieved the deepest response as possible, stringent complete response, MRD negativity, should dream that the disease could be as long as possible in that condition, maybe never representing. We have many patients who are long, we define long survivors, but they are something more. They are long responding. Maybe they are cured, but we don't know. I think the next future will be to develop also some biomarkers that makes us to understand when the disease will represent, and maybe in which intensity, and maybe to prevent that. I think this is the future. However, I think that everything that we think in a long-term outlook should aim to the cure of multiple myeloma. Maybe with the new immunotherapy, we will have something that could definitely eradicate the last cell, and we could maybe be sure that the patient has no signs and symptoms of disease. This is what we have to do in the next future. We have had many good results, but we will be satisfied when we cure 100% of our patients, when we totally eradicate multiple myeloma in all the affected patients.
Yes, absolutely. So I know that there are patients that relapse. How is the risk of recurrence or relapse monitored, and do you explain that to patients, like what to expect in the long term regarding their health?
We have to award the patient at first, even when they are in the perfect condition, when they are in a very good response, that the idea of monitoring that is something that we do because relapse exists. We discuss about patient, in which percentage they could relapse, what we could do in the moment of relapse. This is something also to make the patient aware of the importance of not stopping the monitoring, of not forgetting the visits, the exams that we manage for them. So I think that we have at first to explain that even if we have reached the best results, we have reached our end point, the battle is not won. We have not forgot the myeloma. I think we have to explain that relapse could be something that is a part of this disease, and is not something that could frustrate. That is another moment in which we select something of different. The patient should know. The patient should not think that relapse is something of rare. Relapse exists, but we have different weapons to use, different combination, and we personalize the treatment also in relapse. I always teach to my patient to not look about relapse on websites without any guide. They should discuss with us, they should understand with us. And I think that in that moment, we have also to explain that during relapses, maybe some clinical trials could totally change what we could obtain. And this is the moment in which we discuss also with our patients. However, the idea of always remarking that today, even if we are dreamers, myeloma continues to be a chronic disease. This is something of really important. The patient should understand that it's like many chronic diseases that everyone have, in which we have to perform continuous monitoring and continuous treatment when possible. And also for patients which, for tolerability, for many causes, could not perform the continuous treatment, we should teach them to how is the best way to monitor in order to act in the right moment in which something represents. I think this is the important way. Awareness, training of the patients, speaking about the perspectives. This is what I do in my everyday practice. And I think that if the patient knows that you make them to be part of diagnostic therapeutic process or what's happening, I think that they always follow your suggestions and your ideas. This is the best way. And also the idea to underline to the patient that we have an international view, that today the best opportunities arrives also in our country, and we exchange idea with the best scientists in the world, and that the management is not different between strong European countries and cities from the one that they could perform in United States or somewhere. This is another thing that I discuss about with our patient, because before they had the idea that if you travel in other part of the world, you could find something more in terms of diagnostic tools or in terms of treatments. Today, the difference is not so great. The best clinical trials go everywhere, and I think that they should absolutely understand that.
Absolutely. That's so true. So I agree. And the key takeaways, I think, are communicating with your physicians, patients, talk to your doctor, ask lots of questions. Don't be afraid of clinical trials, and, talk to your doctor about clinical trials. And, they really lead the way to improve treatment. So we're all about clinical trials.
Go about clinical trials, speak with your doctor, talk with your doctor about your doubts, about your when you are afraid for something, but also talk between doctor. We have to share ideas with our colleagues. I think the network is another important key point. So talk with your doctor from a patient perspective, talk with your general doctor when you have some doubt about the journey, but discuss between doctor, create networks, exchange idea, and discuss in board about which is the best opportunity. Let's discuss also about the single case. Let's personalize the treatment together. These, I think, are the key points in this moment for multiple myeloma.
Absolutely. Couldn't agree more. Well, thank you so much for joining us today. We appreciate your time and appreciate all your hard work and your caring for your patients. Thank you.
Thank you very much for this opportunity, and I think that the best wish that we can give to us for what we are doing to the patients and to their caregivers is that we will be able as soon as possible to write the term cure to multiple myeloma. I think that moment is not so far. Thank you for your opportunity.
Thank you so much. Take care.
Thank you. Take care. Bye.
Bye-bye.